So traumatic endophthalmitis management is different. Why? Three reasons I will give. First of all, disorganization of the normal anatomy. In post-cataract surgery endophthalmitis, you are aware of the normal anatomy, but the infection is there. But here, this is a disorganized situation. This is one reason. And the organisms in many instances very virulent. And you still do not have a concrete management protocol. The management protocol is still ill-defined. And if you go back to the epidemiology, approximately around 7% of open globe injury will have endophthalmitis, and the risk is increased by another maybe 5 to 6% if there is an intraocular foreign body. So the risk factors involved in traumatic endoph is a delay in starting the treatment. This is the most important factor. And the type of penetrating injury and at what setting. These are the different risk factors. If the location where the injury happened, maybe some infectious material is there, so which having very virulent organism. So clinical diagnosis is a little bit like this. The symptoms same with or without infection. So it is a little tricky situation because a trauma will have the symptoms similar, and if there is added infection, it's difficult to distinguish sometimes. And very important thing is the constitutional symptoms as fever or vomiting may accompany bacillus. So if you suspect a traumatic endoph, you are not sure exactly, but if you see this patient is having a history of vomiting or a high fever, then you go towards the line of a virulent organism like bacillus. Lid edema, chemosis, proptosis, these are more fevers, is like happening more markedly. Corneal edema, if ring abscess, cell and flare with or without hypopyon, and vitreous exudates, retinal phlebitis, retinitis. All these are some situation that sometimes it may be very confusing. But few things you have to know is constitutional symptoms is more. And most important tip in the management, if it is a penetrating injury, if there is hypopyon, is always suspect of infection. And but organisms, as I mentioned, Bacillus cereus is the most virulent, which give the symptoms very fast within 1 to 2 days. Again, Streptococci is 1 to 2 days. Staphylococcus epidermidis, it is the commonest, which a little bit later Clostridium may be involved, and in some cases it may be a fungus infection. So the management strategy, the treatment should be prompt. A systemic antibiotic you can use, and intravitreal injection you have to give. In many situations it may not be possible to directly go for vitrectomy if you may not be having this all setups, so you have to know how to give an intravitreal injection like you give in post-op end of cases. And vitrectomy, of course, this is early, and if it is a foreign body, intraocular foreign body is there, then doing vitrectomy is you have to do a prompt vitrectomy. And intravitreal injection, as in post-op end, this is this is the first line of the treatment in traumatic endoph also. You choose the antibiotic basically to provide broad spectrum coverage both as in post-op, and subsequently depending on culture and sensitivity you will choose the right antibiotic. And preparation, I think everybody knows how to prepare the vancomycin, all the VR surgeons, but for the general ophthalmologist who is there, so there are some guidelines for preparing the these antibiotics. Vancomycin, you can use ceftazidime, vancomycin, or you can use vancomycin, and you previously used gentamicin, but nowadays it has been replaced. And if you suspect fungal, the amphotericin B. But the points that you have to remember, drugs should be freshly prepared by the surgeon himself. If you are working in a team, like your team member, your fellow can do, but if you don't allow a non-surgeon, like a person who is not that much aware of this drugs, the amount of the drug, so you always try to prepare yourself, and do not try to remember and do it and right. So have a chart keep in your clinic. So the small clips are there how to prepare the this intravitreal antibiotic, but I think it's not it will take some more time. So anyway, so you have to go for intravitreal antibiotic. And during the vitrectomy, EVS doesn't apply to traumatic end-off. The guideline is not exactly what is there in the post-op end-off. So here we do a early vitrectomy, and if there is intraocular foreign body, as I mentioned earlier, it has to be done even at the earliest possible. So doing vitrectomy in end-off is it's little bit different than routine vitrectomy. We use long cannula, and you can do 20 gauge or 23 gauge surgery, but you have to be sure that your infusion cannula is inside. In many instances the anterior segment part is not clear, so you have to make it clear using a side entry and putting a cannula. So sometimes what happens, the exudative material covers the it appears like a sheet which is just closing the covering the pupillary area, so you have to remove those. And before going ahead with this putting the infusion, you have to take a vitreous biopsy. So you take the vitreous biopsy, and routine thing others like any other vitrectomy. So the two important thing, this visibility is definitely poor than normal vitrectomy, that you have to clear. You have seen a foreign body there. So to remove the foreign body, sometimes you have to enlarge the sclerotomy, that you have to again close properly. And prognosis, many instances we can at least save the eye, we can make the vitreous cavity clear, but the retinal function, if you see, in many instances is subnormal. Even if you can see this thinning of the retina. So of course we can control the infection, but prognosis is not that good like in other. So this is the endophthalmitis helpline. One number is there, many numbers there you can have. And finally, if you cannot save the globe, you have to use other modes of weapon. And as you know, Gita has showed, you are the spirit soul, you never die, nothing is going to happen to you, this is happening to the body only. So you have to counsel the patient properly, and definitely